assess ventilation, the ability to inflate and deflate the lungs. And we do that using respiratory volumes. Those respiratory volumes are combined in different ways to give us respiratory capacities, and that will give us information about a person's respiratory status. They're usually abnormal in people with pulmonary disorders. And the main method of measuring them is to use something called a spirometer. Now, spirometers back in the day, and I say back in the day when I was in high school and early in my college career, were cumbersome clinical tools that involved a big tank of water and a huge hose. But nowadays they are small handheld electronic devices that can be used every day, and some of them are not even electronic. Some of them are just the ones that we use quickly to assess asthma are small devices that you just blow into like a straw. But the volumes we're interested in, the things you're clinically going to keep an eye on or be asked to keep an eye on or get measurements about, are tidal volume, which is the amount of air moved into and out of the lungs with each breath. And for a healthy average individual, that's about half a liter, 500 milliliters. The inspiratory reserve volume, IRV, is the amount of air that you can inspire forcibly beyond that tidal volume, and that's typically around 2 to 3 liters. The expiratory reserve volume, the amount of air that you can forcibly expel from your lungs, is around 1 to 1.2 liters. And the residual volume, that's the amount of air that is always going to remain in your lungs. That's needed to keep the alveoli open. And so we can take combinations of 2 or more of these respiratory volumes. The inspiratory capacity would be the sum of the tidal volume and the inspiratory reserve. The functional residual capacity is the sum of the respiratory volume and the expiratory reserve volume. Vital capacity is the sum of the tidal volume plus the inspiratory reserve plus the expiratory reserve volume. And the total lung capacity is the sum of all of those lung volumes. And so you would get a measurement on that spirometer device that would look something like this. If this is your inspiratory reserve, your tidal volume, your expiratory reserve, and your residual volume, giving you inspiratory capacity and functional residue, vital capacity, and total lung capacity. And these are the values for typical adult male and adult female. The dead space in your lungs falls into 2 major classes. There's anatomical dead space. That's the part of your lungs that do not contribute to gas exchange. That consists of the air that's left in your passageways, your conductive passageways of the lungs, and that should be about 150 milliliters to 500 milliliters of the tidal volume, 150 milliliters of the 500 milliliters of total volume. Any alveoli that are not functional would also be or would have alveolar dead space, and that can be due to the collapse or the obstruction of them. So the total dead space would be the sum of the anatomical and alveolar dead spaces. So some pulmonary function tests can be used to distinguish between obstructive pulmonary disease and restrictive pulmonary disease. In obstructive pulmonary disease, we get an increased airway resistance. Bronchitis would be an example of that. So the TLC, FRC, and RV would increase because the lungs are hyperinflated. Whereas restricted disease, which are caused by a reduced total lung capacity because of disease, such as tuberculosis or exposure to environmental agents that lead to fibrosis, the vital capacity, total lung capacity, FRC and RV would decline because the ability to expand the lungs is compromised. And we can use pulmonary function tests to measure the rate of gas movement. So at forced vital capacity, it was the amount of gas forcibly expelled after taking a deep breath. The forced expiratory volume is the amount of gas expelled during specific time interval of forced vital capacity. So that FEV1 is the amount of air expelled in 1 second. And for a healthy individual, about 80% of your functional forced vital capacity in 1 second. With obstructive diseases, they exhale less than that 80%, and those with restrictive diseases exhale more than 80%. Minute ventilation is the total amount of gas that flows into and out of our respiratory tract in 1 minute, and normally at rest that's approximately 6 liters per minute. With exercise, that can go up to 200 liters per minute. It's only a rough estimate of respiratory efficiency. What it really tells you, the alveolar ventilation rate is the flow of gas into and out of alveolar during a particular time, and that would be a much better indicator of effective ventilation, because that gas has to go through the alveolar, not just the lungs, to get to where it needs to be. So the alveolar rate takes into account the amount of dead space, the tidal volume, and the rate of breathing. And if we were going to calculate it, the AVR would be equal to the frequency, which would be breaths per minute, times the tidal volume, divided by the dead space. And because dead space is normally constant, that AVR is really affected by tidal volume and frequency. So a significant increase in AVR brought about by either increasing the tidal volume, not increasing the frequency. So rapid shallow breathing can be used to decrease the alveolar rate. Gas exchange, what's really important for us, occurs between the lungs as well as between the blood and the tissues. External respiration is the diffusion of gases between the blood and the lungs. Internal respiration is diffusion of gases between the blood and the tissues. And both of these are subject to the basic property of gases and the composition of the gases within the alveolar. Dalton's law of partial pressure says that total pressure exerted by a gas mixture is going to be the result of the sum of each of the gases in that mixture, which brings us to the concept of partial pressures. Partial pressures would be the pressure exerted by each gas in a mixture, and it's directly proportional to the percentage of that gas in a mixture. So the more of that gas, the more of the total pressure is due to a particular gas. So we said the total atmospheric pressure at sea level is about 760 millimeters of mercury. Nitrogen makes up about 78.6% of air, so the partial pressure of nitrogen would be calculated as 0.786 times 760, which is roughly 597 millimeters of mercury because of nitrogen. So the percentage times the total pressure gives you the part of that pressure. So what we are saying is that of the 760 millimeters of mercury pressure atmosphere, there 597 of that are due to the nitrogen. Oxygen makes up about 21%, 20.9 of air, so its partial pressure would be 0.209 times 760, which would be 150 millimeters of mercury. So of that 760 millimeters of mercury in atmospheric pressure, 159 of it is due to oxygen. Air also has about 0.04% CO2, 0.5% water vapor, and other gases, but they would not be in significant amounts. As you go higher in altitude, partial pressure decline. If you go below sea level, particularly underwater, partial pressures will increase. So, speaking of laws, Henry's law says for a gas mixture that is in contact with liquids, each gas will dissolve in the liquid proportional to its partial pressure. So the more partial pressure, the more of that gas that will make its way from the air to the liquid. At equilibrium, partial pressures in the two phases will be equal. So the partial pressure in the liquid will equal the partial pressure in the gas. And the amount of each gas will depend on a couple of things. First of all, its solubility. Carbon dioxide is 20 times more soluble in water than oxygen. Nitrogen is not soluble in water. And temperature will also have an effect. As temperature liquid rises, the solubility tends to decrease. So we can use Henry's law when we have to put a patient in a hyperbaric chamber to increase the amount of gas in the liquid. And in this case, the liquid we're concerned with is blood. So breathing oxygen at 2 atmospheres is not a problem for a short period. However, oxygen toxicity rapidly develops if the partial pressure of oxygen is greater than 2.5 to 3 atmospheres. So as usual, the dose makes the toxin, and too much oxygen is toxic. Excessive high oxygen concentration generate a lot of free radicals, and they can result in central nervous system disorders, coma, and even death. So alveoli contain more carbon dioxide and water vapor than atmospheric air because of the gas exchange that's going on. We've got oxygen leaving the lungs, going to the blood, carbon dioxide coming out of the blood and going into the lungs. The air that's coming in has been humidified. We talked about that going through the nose. And the mixing of the alveolar gases with each breath. Newly inspired air is going to mix with air, but some of that air was left from the last breath. We're not emptying the lungs and refilling them every time. External respiration or pulmonary gas exchange is going to involve the exchange of oxygen and carbon dioxide across respiratory membranes. And therefore, with those things we've just been discussing, keep in mind that will be influenced by the partial pressure gradients and the gas solubilities. In addition to that, it'll be influenced by the thickness of and the amount of surface area of the respiratory membrane. And because of that, and we touched on this when we talked about circulation, there will be ventilation perfusion coupling. You match the alveolar ventilation with pulmonary blood perfusion. We want to put the blood where the oxygen is available. So partial pressure and gas solubilities. A steep partial pressure gradient for oxygen between the blood and the lungs. In venous blood, the partial pressure of oxygen is approximately 40 millimeters of mercury, whereas in the air, in the alveolar, it's about 104 millimeters of mercury. So there's a steep concentration gradient, partial pressure concentration gradient between the alveolar and the blood. So that's going to drive oxygen into the blood. Equilibrium is going to be reached across that membrane in about 1/4 of a second, but it takes red blood cells about 3/4 of a second to travel from the start to the end of a pulmonary capillary, and that gives time for the oxygen to be picked up by the red blood cells. Partial pressure for carbon dioxide is not as great. In venous blood, it's about 45 millimeters of mercury. In the alveolar, where we want it to be, it's 40 millimeters of mercury. So it's not as steep a gradient, but carbon dioxide is 20 times more soluble in plasma than it is in the fluid of the alveoli. So that solubility is going to help move the CO2 where we want it to be. So in the alveoli, our inspired air has a partial pressure of 160 millimeters for oxygen, 0.3 millimeters for mercury. For carbon dioxide. In the blood, we have 40 millimeters for oxygen, 45 millimeters for hydrogen. And pushing oxygen in. Actually, I'm going to let you follow this chart on your own. Over here, the lungs, 104 millimeters, 40 millimeters. And we'll get into these details in a second. So at the start of a capillary bed in the lungs, we have a partial pressure of oxygen of 40. it will go up to close to 104 as it reaches equilibrium with the air in the alveoli by the time it reaches the end of the capillaries. So we are going to oxygenate hemoglobin over the course of 3/4 of a second. So the thickness in the surface of the respiratory membrane also plays a role. Respiratory membranes are generally very thin, between 1/2 and 1 micron, which is very, very small. Total surface area is 40 times the surface area of the skin. So you have 40 times more surface area in your lungs than you have on the entire outside of your body because of the way the lungs are put together and that branching tree and the alveoli in them. So the effective thickness of a respiratory membrane will increase dramatically if the lungs become waterlogged or swollen edematous, and that can be seen in things like pneumonia, again, very apropos with COVID-19 going around, but it also happens in left side heart failure. In that case, that 3/4 of a second that red blood cells spend in their transit through the capillaries is not enough for adequate gas exchange, and that means that the tissues are going to suffer from oxygen deprivation. Certain pulmonary diseases will also drastically reduce the amount of alveolar surface area. Emphysema, for example, and the walls of adjacent alveoli break down and the alveolar chambers enlarge, so you get big alveolar instead of lots of little alveolar. That cuts down on surface area. Tumors, mucus, inflammatory material can also reduce surface area by blocking gas flow to and from the alveoli. So here is a normal lung with all kinds of little alveoli joined together with connections between them, but they're still each small with a lot of surface area. That amount of surface area is gone in an emphysemic patient. Instead, you have larger alveolar. Internal respiration is the result of ventilation-perfusion coupling. So perfusion is the amount of blood that gets to an individual alveolar. Ventilation would be the amount of gas reaching the alveolar. So ventilation and perfusion rates have to be matched if we want optimal, efficient gas exchange. They're going to be controlled by auto-regulatory mechanisms, and these auto-regulatory mechanisms are local auditory regulatory mechanisms. So the percent oxygen, or partial pressure of oxygen, controls perfusion by changing the arterial diameter, and the partial pressure of carbon dioxide is going to control ventilation by changing the bronchial diameter. So the partial pressure of oxygen in the alveoli is going to, the more oxygen in the alveoli, the larger the diameter of the arterioles, so that more blood will come to those alveoli. If alveoli have a lower level of oxygen, they'll constrict the arterioles, so the blood will bypass them and go somewhere else where there is oxygen. So this is going to direct blood to go to the alveoli where oxygen is high, so blood can pick up more oxygen. The opposite mechanism is seen in systemic arterioles. Remember, the systemic circulation is different than the pulmonary circulation. In the systemic circulation, we want blood to go where oxygen is low so we can deliver it. Carbon dioxide in the alveoli will change the diameter of the bronchioles. So when there is high level of carbon dioxide in the bronchiole, you dilate the bronchiole, or in the alveoli, you dilate the bronchiole, so more air comes and exchanges that carbon dioxide. If there's a low level of CO2, you can constrict the bronchioles and you use the oxygen that you have. That will allow the elimination of carbon dioxide more rapidly and efficiently. So we're going to balance ventilation and perfusion. Changing the diameter of local arterioles and bronchioles will synchronize this ventilation perfusion. Ventilation perfusion is never balanced for all the alveoli because there are regional variations that may be present, and that could be due to the effect of gravity, on blood and airflow. And occasionally alveolar ducts become plugged with mucus and cause unventilated areas. So with when ventilation is less than perfusion, mismatched ventilation and perfusion, we have low ventilation and high perfusion of alveoli. That would cause local increases in CO2 levels and decreases in oxygen levels. So the pulmonary arterioles that serve those alveoli would constrict, and that would match up perfusion, and that would balance the perfusion eventually and decrease ventilation. So we can also have increased ventilation and low perfusion would cause a local decrease in CO2 and increase in O2. That would lead the oxygen to open the arterioles. The pulmonary arterioles come to those. They would match up the perfusion in that way. Internal respiration involves capillary gas exchange in body tissues. The partial pressure and diffusion of the gradients are reversed compared to the external respiration. So tissue partial pressure of oxygen is lower than in arterial blood, 40 versus 100. So oxygen tends to move from blood to tissues. Tissue CO2 is always higher in the arterial blood, so is always higher than the arterial blood. It's always higher in the tissues. CO2 is higher in the tissues. It moves from tissues to blood. So ending us with what we started before when we talked about exchange, the venous blood tends to have a partial pressure of oxygen of 40 millimeters of mercury and CO2 of 45 millimeters of mercury.